Okay, good morning. It is now Wednesday, September 16th, week 7. This is MED110, Anatomy and Physiology 1. This is Dr. Garais, term 4. The lectures will be done via Zoom for this week and next week. I just posted the revised lecture for last week because remember, we are in laboratory. So week 7, we have laboratory this week, so please schedule your laboratory. We have some people who came in yesterday, and then some people who are coming in Friday and Saturday of this week. So make sure to also have my cell phone number just in case the doors are closed. Much less for the morning people, but sometimes in the evening they accidentally close the doors, and sometimes on the weekends, but the nurses have laboratory in the weekend as well, so they should be there as well. This week's topic is the respiratory system, chapter 22 in your textbook. So let's, of course, watch the videos and let's utilize our textbook for kicks. And of course, I will always refer back to, I'll always refer back to like pictures, because remember, this is anatomy and physiology class. So let's open our textbook, OpenStax. It's a nice resource. I'm trying to use it more. So let's open this up and open up the table of contents. And then, what was it, chapter 22? Okay. Now, the function, the word respiratory means the exchange of gases, oxygen and carbon dioxide. And oxygen, we already know, is required along with glucose to make ATP. That's why we have to breathe. We already talked about gas exchange or respiration at the cellular level. We also talked a little bit about that in last week's cardiovascular. But this week, because we're going to be talking about cellular respiration on the pulmonary level, on the lungs. So let's close out this table of contents. Let's make this a little bit bigger. If you look at the parts of your pulmonary system, you have an upper respiratory, which starts from the trachea on up, and then the lower respiratory. The upper respiratory system, what am I trying to say, is composed of your nasal cavities, your oral cavities, and of course your throat and your pharynx. So getting pharyngitis or rhinitis, that's an upper respiratory tract infection. And even sinusitis, which is also part and parcel of the upper respiratory tract, because you also have sinuses here, these little chambers or little rooms inside your skull. When all of that gets infected in your larynx, your voice box, all that gets infected, laryngitis, pharyngitis, rhinitis, and sinusitis, those are upper respiratory tract infections. And those are things that do not require typically you going to the hospital. But anything from the trachea on down, which is lower respiratory tract infections, that's a problem. So your trachea, your bronchus, and of course your lungs, infections in those areas like bronchitis, emphysema, COPD, chronic obstructive pulmonary disease, which is essentially chronic bronchitis and emphysema, and pneumonia, of course, fluid buildup in your lungs. Those are serious things, and that warrants serious concern and a potential visit, at least to an urgent care. So there are the lower respiratory tract infection is also important, is because the lungs is and deep inside the lungs is where gas exchange really is going to occur. And from the trachea on up, those, because in respiratory medicine, we call that dead space, because it doesn't it doesn't seriously contribute to gas exchange. Like oxygen and carbon dioxide are not exchanging up here, they're exchanging down here. Okay, so that dead space is also called the conducting zone or conduction zone, and it has mucus in it. It traps foreign object and potential pathologic items like dust, bacteria, and even some viruses. And again, it's part and parcel why we wear our mask, not necessarily to not necessarily to block everything, but to decrease the amount of potential pathogens that are coming into our respiratory system. And nowadays, with the pandemic, it's a considerable concern because SARS-2 COVID-19 has a predisposition for lung tissue. Hence, if I block the main entrance that's going into my into my respiratory system, or like at least filter it a little bit, it will decrease the chances of me getting a virus or any other infection. And that's actually the rationale and reasoning behind considerable amounts of PPE or personal protective um, uh, personal protective wear for medical professionals. Now, your nose. Okay. Quickly, I remember we already talked about how you have cartilage which is flexible, and we already talked about how the nasal area. We're going to talk a little bit more about that when regarding olfaction or the ability to smell in special senses in MED110. But the nose and all the associated anatomy here has increased surface area, again, for mucus. You could also see the nose has a septum, which divides the nares or nostrils into a left and right. And again, you could see how any obstruction, like a deviated septum, right, or any inflammation or infection of these turbinates, like in rhinitis, can seriously affect the pathway of going into your trachea. Now, you'll also notice the trachea has cartilaginous rings, and they're C-shaped, and they only cover the front. And we will see in dissection that it only covers the front because the back part is the esophagus or food tube. And this space can't be totally rigid. It has to have a little bit flexibility so that when you eat food, and of course the epiglottis here closes down when you eat food, therefore you shouldn't be talking while you're eating or drinking. When you eat food, this, of course, the esophagus will expand. So when you're actually eating or drinking, you're actually holding your breath for a little bit. And again, like I stated, any infection here in the upper airway is, it's annoying, it's not, but not really cause for concern, massive concern. Okay. Hard palate, soft palate. So again, another outline of it. Now let's get down to your larynx or your voice box. Your larynx or a voice box, again, in dissection, we're going to see that when we cut out the larynx is also cartilaginous, and it has this soft tissue, muscular tissue called your epiglottis. The function of the epiglottis is to make sure, again, like I stated, when you're drinking or eating, the food only goes down the esophagus. Because if food, which is essentially dirty, right, goes down and, or even vomitous, if it goes down into your trachea, into your lungs, you could get aspirational pneumonia, and that's very hard to treat. And that's also the reason why you're not allowed to eat prior to surgery. And we actually kind of, in some surgeries, give you detergent to make sure everything's out of your colon and everything's out of your stomach. Because if anything comes back up, and of course you're unconscious, it could go into your lungs and aspirational pneumonia, and that's a problem. You could also see that on your vocal cords have a set, they have true folds and false folds. But you could see, just like the strings of a guitar, when the strings of the guitar are nice and free and clear, right? You strum them, and what will you get? You will get a beautiful sound. But what happens when there's lots of mucus, inflammation, or infection, or cancer that gets into these folds? It will hold it down like the same exact way that you hold down strings. And then it'll be muffled, and then that's where you get hoarseness. So when you get aphonia, or you can't speak, the infection is so bad that these folds cannot vibrate. And if they can't vibrate in your larynx, then you won't be able to talk. Okay, and your larynx here is cartilaginous and has cartilaginous folds as well. And here are the cartilage rings on your trachea. Now, as your trachea descends into your right mainstem bronchus and your left mainstem bronchus, let's look at that. Won't let me get bigger? Oh, there you go. Okay, you will notice that there's a lot of, in the beginning of your mainstem bronchus, there's still a lot of trachea, but little by little by little, as you go deeper, the cartilage will start to disappear and will give way to smooth muscle. And we're going to talk about the function of that later. And there's, of course, a lot of mucus glands, right? And pseudocytified columnar epithelia. Remember, there's an inside skin. And, of course, decent amount of cartilage, okay? And cartilage is not as rigid as bone, but it's rigid enough to keep this airway open. You'll also notice how the right airway is a little shorter and more vertical than the left. Therefore, any foreign body that will accidentally drop into your respiratory system, like, for example, in the case of pneumoconiosis, like asbestosis, you know, those fine particles such as, asbestos or dust or coal dust can easily fall down, and will typically fall down more on the right side than the left. Because if you'll notice here, the right side is a little shorter and is a little bit more steeper. So you can see how foreign body can get in there. And foreign body is not a good thing for the lower respiratory tract system, because it'll not only get in the way of gas exchange, which is really important to us, right? It will also spark an immune system. And just like people who have of asthma, and we're going to talk about the role of smooth muscle right here on the end parts of the lungs regarding asthma. Okay, so trachea, bronchial tree, you have your right and left. Oh, I forgot to mention, the bifurcation or the crossroads between the right and left mainstem bronchus is called your carina. C-A-R-I-N-A. Where's the word here? Here's the word right here. Okay, so now let's get into the respiratory zone versus the conduction zone. Also and the conduction zone is the upper respiratory tract, and also known as the dead zone, because it doesn't really contribute to to gas exchange. What does contribute to gas exchange? Well, there's these bunches of grapes called alveoli. They are at the end of the bronchioles. So the bronchus gets smaller and smaller and smaller, right? As we saw here. And then it gets smaller and smaller and smaller, and then it ditches this cartilage for smooth muscle. And remember, we were talking about a second ago about asthmatics. Well, asthmatics, their immune system is very, very sensitive. So when even the littlest dust particle gets into the respiratory system, it signals massive amounts of mucus and massive amounts of constriction in these smooth muscles. Hence, sometimes you get the wheezing, and then also you'll definitely get the dyspnea or the shortness of breath. And then they'll have, and if all of this starts squeezing, oxygen and carbon dioxide don't exchange very well. So you could see here where you have the deoxygenated blood here into your capillaries, and the capillaries are only one cell thick, and that's why they're associated with the alveoli, so that the gases go in and out. So you could see these capillaries, and the blue side, that's going to give the lungs the carbon dioxide, and then you exhale that. And then when at the same time, when you inhale, right? Well, not at the same time, after you exhale, because when you inhale, all that oxygen that you get from the environment will now go into your oxygenated blood, and then back into your heart. And we just talked about that in the last lecture. And then all of it then ends up into your left atrium, and the cycle starts all over again. So you can now see where if there's a lot of mucus here, as in the case with bronchitis, as also in the case of asthma, your patient won't be able to breathe, won't be able to have gas exchange. Now, in the case of pneumonia, right? In pneumonia, there's a fluid level that builds up in the alveoli. Now, your lungs don't like to be dry, nor do they like to be wet. They like to be moist, somewhere in the middle, so that there can be efficient gas exchange. But in the case of pneumonia, it's too much water, and that's why we can't breathe underwater. And that's why pneumonia, it's like drowning in your own tissue fluid. And one of the most severest types of pneumonia I just mentioned was aspirational pneumonia. And also another type is associated with HIV/AIDS patients. When they get full-blown AIDS, they get pneumocystis carinii pneumonia, which is very intractable, very hard to cure. And the fluid level just gets worse and worse. And my patient gets has way more difficulty and progressive dyspnea. So another thing that also happens is also in emphysema, which is part of the COPD, chronic obstructive pulmonary disease. In emphysema, these alveolar sacs get distorted and they get really, really big. Now, you would be thinking that, hey, that might be a good thing. But remember, homeostasis means somewhere in the middle. I don't need these things super tight, as in the case of bronchitis or asthma. But in the case of emphysema, which is usually the case in chronic smokers, emphysema will enlarge all these alveolar sacs, and then it will dilute the oxygen being taken in. And if that happens, because remember, the oxygen being taken in is only 21% of atmospheric. So you have now a bigger space, that 21% will get less, far less. My patient will then, of course, have dyspnea, shortness of breath, and will be hard of breathing. So you could see how all these things, whether bronchitis, emphysema, even lung cancers, anything that blocks or prevents this respiratory zone from conducting its business gets really dangerous. Hence the term lower respiratory tract infection. Hence, it's something that we should be wary of, okay? Another thing that we have here in our lungs is surfactant. Surfactant is a chemical that helps us maintain water tension in the alveoli, which helps with gas exchange. Now, these are produced by type 2 alveolar cells, and that makes sense. It's in the alveoli. There's also alveolar macrophages, remember, part of our immune system. They're phagocytic cells that eat up, phago or phagio, potato, if you will. That means to eat. So they eat cells that don't belong there. And you could see how bad an autoimmune disease would be, because then they can't tell, then they start eating up lung tissue, and they start eating up things that they shouldn't eat. And surfactant's really important, especially with newborns, because premature newborn babies, sometimes their type 2 alveolar cells aren't developed well enough, like especially babies are born around 30 weeks age of gestation. They don't have pulmonary surfactant, and that will prevent proper gas exchange. I was one of those babies. I was born around 30 weeks age of gestation. I was in an incubator for about 6 weeks, where they had to pump extra oxygen because the gas exchange, because of lack of surfactant, was of issue. And then they also gave me meds to boost up my surfactant as well. Okay. And you could see the difference. If there's way too much mucus, it's a barrier, right? There just needs to be a nice thin layer of mucus, right? Another thing you'll also see, look at all the infection. There's mast cells and macrophages way more than you would see in a normal cell. Yes. Hold up. Excuse me. One moment. Now, okay. Let's go to the next. All right, so those are the lungs. Now, another thing about the lungs is they are in sections, okay? Now, the sections are, hold up, I gotta pause, I'm being called. Okay, I'm back. Sorry about that. Now, when we look at this picture of the lungs, of course, these are trachea, the carinae. You have your right main stem bronchus and left main stem bronchus. This is the left side, this is the right side. And again, please note that when you look at it, you look at things in the perspective of the patient. You will see that the left lung has 2 lobes and the right lung has 3. The left lung also has a cardiac notch to facilitate the space of your heart. Okay. Now, the reason why our lungs have lobes is so it can sequester damage and or cancer. So if I get cancer in one lobe, it'll be a little bit harder for the cancer to go spread to the other lobe. So it'll kind of, use that as a little bit of more of a protection. And also if we have cancer here, like in the inferior lobe in the left lung, it can, because we can do a lobectomy, remove that inferior lobe, get that cancer out of there, get that damaged part, and the patient still can breathe. So the left side has a superior lobe and an inferior lobe, which is separated by this line right here. Now, the right lung has a superior lobe, middle lobe, and an inferior lobe. Okay, so that's a nice comparative question. Now, we already talked about pulmonary artery, pulmonary vein. Now, remember when we talked about the kidney and we had a hilum, or in some textbooks, hilus? Well, guess what? It goes, the lung also has something similar because things connect into the lung. So for example, in each lung, the hilus or hilum, there has to have a pulmonary artery, pulmonary vein, and which of course connect into the lung, and of course a main stem bronchus. So doesn't that look like a wonderful all of the above question? Another thing that you'll also notice that in dissection is the heart and the lungs and many other tissues all have coverings. And the coverings are typically done in 2 layers. Okay, so you have your visceral layer and your parietal layer. The visceral layer is the inner layer and the parietal layer is the tougher outer layer. Now, there's a pleural cavity in between the space, and in between that space is a little bit of fluid to keep the movement of the lungs lubricated. Now, when you get pleuritis, it'll present with pleurisy, which is pain, typically in your sternum right here. You know when you get a really bad cough, and every time you cough, it feels like a knife, or it feels like sandpaper grating right here on your chest? Well, that's because the nerve endings here are sensing that there's either pus or excess fluid, or even in severe cases, blood, okay? And it'll cause pleurisy, which is chest pain secondary to, inflammation or infection of this potential cavity. Now, remember, Visceral and parietal pleura. The visceral is the inside, the guts. And when you have two things you got to memorize, you memorize one like your life depended on it, and your other one, and the other one is simply the other one. So I always remember visceral, guts. Same thing with your heart. You have a visceral and parietal layer. There's a little bit of fluid in between for lubrication so that the heart can not only be protected, but the heart can keep on pumping without any friction. But the same thing for the heart. If anything like pus or blood gets in there, that's bad news for the heart. Okay? Now, let's now go to breathing. How do we breathe? Now, there's a formula, and it's called, you don't need to know it. Well, you'll eventually need to go. Let's just say it. It's Boyle's Law. But I'm not going to do any math for this course, but eventually one of these days you're going to do math. But all it states is that when you press down on something or increase pressure, right? When you press down and when you increase the pressure of something, the volume will always get smaller, okay? So that means there's an inverse relationship between pressure and volume. When the pressure gets higher, the volume gets smaller, okay? So how do we breathe? All right. Now, remember we also talked about osmosis and diffusion. Now, remember diffusion always goes from an area of high pressure to the area of low pressure. So this is how we kind of force the lungs to go suck in some air during inspiration. Your diaphragm bottoms out, and your external intercostal muscles start contracting, right? So what happens? When they contract and the diaphragm contracts, it's going to create a negative pressure within your lungs. And the atmospheric pressure is positive. So if there's a negative pressure in your lungs, air will now flow inward, hence inspiration. Then when the pressure in your lungs gets greater and greater and greater until it's now the pressure in the lungs are greater than atmospheric pressure, then what will happen? You'll expire or get air out of your lungs. And typically we're getting inspiring for our oxygen. Then we have gas exchange. Then there's a pressure buildup. Once the pressure is great enough, and then I'll take all the carbon dioxide, right? And then it will do what? Expel all the carbon dioxide. So what kind of question could I ask you, right? In inspiration, goes, which has a greater pressure, lungs or atmospheric? Of course, atmospheric. So it goes from atmosphere into lungs. The lungs will have a negative pressure, mainly because of your diaphragm contracting, right? So it acts like kind of like a syringe. So it draws or sucks up air. Now in expiration, it's there's a greater pressure inside the lungs versus atmospheric. So just what diffusion, the laws of diffusion state, it'll go in, right? And of course, you could see that the lung volume is getting smaller. And if the lung volume is getting smaller, then the pressure has to increase. Pressure is increased here, pressure pushes out, okay? So I could ask you, right? When I'm expiring, you go, which is greater, expiration or inspiration, lung volume? Lung volume on expiration is what? Lesser. See how it's less than this? But the pressure or expiration is greater in the lungs, hence that's why you expire or exhale, all right? And that's a classic NCLEX physiology question because it relates to lung volumes and lung capacities, all right? And it is not within the scope for this particular class for lung volumes. Just know that you have tidal volume is your normal breathing volume. And then you have inspiratory reserve volume, the extra, right? And then you have expiratory reserve volume, and then any residual volume. And eventually you're gonna have to memorize these things because again, this is another clinical NCLEX question. Or if you're going to medical school, this is definitely an MCAT question. Like, so what's the inspiratory capacity? Well, of course, it's inspiratory reserve volume plus the normal amount of volume that you usually breathe, right? And you could see here, like it's around 3,000 to 6,000 milliliters. So that's what, about 3 liters, give or take, right? And then you have another like 2 or 2.5 for functional residual, which is your expiratory. So you have way more inspiratory capacity than expiratory. And the vital capacity is what is the amount of lung volume that's required for vital, for life, okay? And we measure vital capacity, and you could see here, like, especially if you have any of those lower respiratory tract infections that we talked about, when your patient starts breathing in, it looks like a breathalyzer tube connected to a mini computer, it'll start giving you lung volumes. Falls Church has one, or had one at one time. I remember like 10 years ago, we were playing around with it. Not 10, maybe 6 years ago. So I might ask a side question about this, but nice to know. The other stuff that we mentioned, a little bit more important. Now, you have respiratory centers all over your body. So we're gonna briefly discuss like, how does your body know how to breathe? Well, the main part of how your body knows how to breathe is essentially the partial pressure of carbon dioxide. And that main part is located in your spinal column and your cerebrospinal fluid. That is the main controller of how you breathe, the amount of carbon dioxide in your system. And the medullary respiratory center in your medulla, right? Remember, and well, not remember, I didn't give that lecture yet, but when we're in lab, oh no, not for you guys. Or is it for you guys? MED2, no, I don't think it's for you guys. But whenever we start talking about the brain, all the vital capacity stuff, all the stuff that can kill you like really easy, whoever built us perfect. There, it's all the way in the back and it's deep, and your medulla is all the way in the back and it's deep. So all these kooky people trying to kill themselves by blowing off the front part of their brain, that's your frontal lobe. You can blow that part out and you could still live. But the vital stuff is all the way in the back, right? And if you can see here, they're in the back and they're deep. It makes sense. It's all covered with skull and spinal column. Okay. Now you have internal and external intercostal muscles. They help you breathe, but internal, external intercostal muscles and your diaphragm are the main main muscles of breathing. When you start using other muscles or start hunching over, start using your shoulder muscles, those are called accessory muscles. That means you're having a bad time, and odds are your patient is going through dyspnea, also known as shortness of breath, or SOB. And you could see the ventral respiratory group and the dorsal respiratory group. They call that because those are the respiratory groups within your spinal cord. You have a ventral one, right? And a dorsal one, right? Okay. And again, it gets really dangerous. If I sever my spinal cord in the cervical area, or if I have a basal skull fracture here, can you breathe? Nope, you're gonna have a rough time. Okay. And remember, CO2, carbon dioxide, is the main chemical that gets monitored, and it gets monitored through chemoreceptors. You have a central one, of course, in your brain stem, and then you have a peripheral one, which is located in your carotid artery and your aortic arch. That's why when you do stuff like sleeper holds, or what we call in MMA, mixed martial arts, as rear naked choke, what are you really doing? You're grinding down, not really on your throat. Well, you are a little bit, but you're grinding down on the anterior portion of your neck, which houses these chemoreceptors. You start squeezing on that, it tells your respiratory system to stop breathing as much. And of course, you're panicking, someone's choking you, It's not a fun deal. Now they start going into these complex things you don't need to know. Not part of the scope of this particular class. Now, respiration. How does that actually work? It, again, works through diffusion. So if there's a buildup of carbon dioxide within our lungs, right, that'll be an area of high concentration, right? So that has to go out of our lungs. And if there's a buildup of oxygen in our lungs, that's a high concentration of oxygen. And then there's a low concentration in our blood plasma and in our red blood cells. So then the oxygen will then go from an area of high concentration, our lungs, into the capillaries to an area of low concentration. And that's pretty much how you actually breathe. It's gas exchange, also known as respiration, from areas of high concentration to areas of low concentration. And that's why we're breathing. We want, once you get rid of that carbon dioxide, then what? It goes, then the oxygen comes in. Now, how do we transport it? Well, within, it's a little bit primer of red blood cells and blood, but the red blood cell, in the middle, there's no nucleus, but in the middle, it has hemoglobin. Hemo means blood, globin means protein. This hemoglobin protein, as you can see here, which is just a chain of amino acids, you can see like there's four, can you see there's 4 zones? And there's seats. There's seats where oxygen or carbon dioxide would go. And also, there's also seats where sugar would go. That's why we look at glycosylated hemoglobin or HGB 1AC. So I can tell for the last 90 days how much you've been eating. We also can look at the hemoglobin on how well does the hemoglobin hold oxygen and get rid of it. Okay. This other stuff is more pathology. And now you know where exactly, how exactly does the red blood cell carry oxygen and carbon dioxide around. And remember, in arteries, typically the red blood cells have a lot of oxygen. And in veins, typically the red blood cell is carrying way more carbon dioxide. And we already known that from. So high altitude effects. Now in high altitude effects, just and even in diving and things like that, remember, it's all about pressure and pressure gradients from high to low. And you could see that if you're in a place that has very thin air, very low pressure, it's going to be harder for you to breathe, and you have to be on that mountain for a little while to get acclimatized. And then you could get mountain sickness. And again, unless any of y'all are climbing mountains anytime soon. Anything else? No. You know what? Let us look at to see if we covered everything, which I believe we did. Okay, this and this and this. Let's look at our objectives, because I just pretty much ran with it with this particular lecture. But let's look at our objectives to see if we met everything. Again, we're in week 7. Respiratory system as a whole, we know all the parts. Here's some nice notes from Carolina Labs. Let's see what they have to offer. It's probably the same thing, but in record, you know, in text form. We talked about carbon dioxide, homeostasis, ATP, erythrocytes. How do you breathe? All the parts. Yeah. Some lung volumes here. Okay. And of course, we're not doing the lab. We're in lab, we're doing dissection. How do oxygen transport and how it goes. Now, here's a nice little video. Watch this, ATP and respiration. But essentially, we already know this. We already had this in week 2, week 3 lecture. Oxygen and carbon dioxide, not oxygen and glucose, 6-carbon sugar, enter the cell. It goes inside the mitochondria. The mitochondria then goes through the electron transport chain to create ATP. ATP, adenosine triphosphate. The phosphate bonds are high energy bonds, and that's how we live. The second you stop eating, you cut off your glucose, or the second you stop breathing, right, in cardiac and or respiratory arrest, you will cease to exist, because and then there will be a whole bunch of chain of events because of there is no ATP. And at that level, that is also called cellular respiration, because that's oxygen and carbon dioxide going in and out of cells. Okay. Pulmonary respiration is the carbon dioxide and oxygen going in and out of your lungs. And then you also have respiration between your blood vessels and your organs as well. So all respiration means is gas exchange, carbon dioxide to oxygen. We talked about the structure of the respiratory system. We talked about how gas exchange occurs. And we also talked about the transport of oxygen and carbon dioxide. So I think we are good. See what anything else will we, of course, do for week 8. Do your concept map. Again, this hybrid and online are the same. It's wash, rinse, and repeat. Now here, technology. And again, I'll be attending training. There is a new APA format, but I'll only hold you guys to the current APA format that we're doing. But I've been told that the new APA format will be simpler and easier to use. So I'll bring that training to you, and if there's a recording of it, I'll put it on announcements. But again, when you're looking for technology, try to look for things that a year or two, something from like 2015. It's like saying, I want to talk about my new phone from 2015. Remember what your phone looked like in 2015? It could do nothing compared to what our phones do now, 5 years ago. So when you're talking about technology, please, try to pick something from the last couple of years. But the rule is 5 years is good. But when you think about it, picking something from 2015, and some of you just write, oh, give an answer. You have to do the benefits, do some pros and cons, okay? And also others do the exact opposite. Some of you write a book report. I don't need 1,000 or 1,100 words, because anywhere from 250, 200, 250 to like 400 should suffice. But man, some of you, Sylvia Plath of Stratford University discussions, all right? Remember, homeostasis. You don't want too little, you don't want too much. You want it just right, just like the 3 bears. Or was it Goldilocks? I don't know. I don't know who's the star of that particular story. Glycolysis and Krebs cycle and application assignment. Let me look at it real quick. Cellular respiration. Let's look at answers part 1, part 2. Yep, answer all parts. Parts 1 through 4, there should be enough. And again, if you just Google the answers, that should be sufficient. But you should have everything you need from the lecture and from just reading the case. And just as a little preview, I'll be proposing to the curriculum committee to not only shorten up these cases, but have these cases lead to like quizzes versus, so it prepares you better for midterms and finals and for things like MCAT and NCLEX. All right, on that note, thank you very much, ladies and gentlemen, for watching this video, and I'll see you in lab or see you at the next Zoom session. Okay, please look out for your announcements for any pertinent changes in schedule. Have a good one.